Hello everyone, and welcome to Introduction to Nutrition Support. In each module, you'll have readings and lecture PowerPoints. Often you refer to the readings, especially specific portions within the enteral and parenteral handbooks. Be sure to take notes, as my commentary goes a little bit more in depth than what is presented in the slides, and you could be tested over it. Let's get started. So in this module, we'll be talking about some definitions, indications for nutrition support, nutrition screening, nutrition assessment, and nutrient needs. For the introduction section of this course, there are several components from the Nutrition Support Core Curriculum, the NSCC. I've chosen not to require this book, but instead the handbooks that are also from Aspen. The handbooks I think will prove to be helpful in your practice and probably provide easier access to the material than the Nutrition Support Core Curriculum. You don't have to read the entire chapter, but do make sure that you have the knowledge base needed to move on to the enteral nutrition and the parenteral nutrition discussions. For example, Chapter 1 is on nutrient screening, assessment, and care plan development. It may be pretty, quote unquote basic, but it's still very important. Chapter 2 is an overview of enteral nutrition and patient selection. It includes indications and contraindications of EN, types of devices, and formula selection, and also ethical considerations. Chapter 6 covers nutrient requirements, administration methods, and order protocols, as well as a few other topics. So why is nutrition support valuable? With the increasing importance that is being placed on value-based medicine, Aspen initiated the Value Project to measure healthcare outcomes against the cost of care delivered when nutrition support is provided. The study, The Value of Nutrition Support Therapy, Impact on Clinical and Economic Outcomes in the United States, was published in JPEN, which is Journal of Parenteral and Enteral Nutrition, and it found that there was a Medicare cost savings of $580 million that was provided in the following high priority therapeutic conditions: so sepsis, gastrointestinal cancer, surgical complications, and hospital acquired infections. So first, some definitions are needed. This is a very simple definition, and it's found on nutritioncare.org. Nutrition support therapy is the provision of enteral or parenteral nutrients to treat or prevent malnutrition. Nutrition support therapy is part of nutrition therapy, which is a component of medical treatment that can include oral, enteral, and parenteral nutrition to maintain or restore optimal nutrition status and health. Remember that oral nutrition can also be enteral nutrition, however, it's rarely thought of in that way. Nutrition therapy is just the broader term for oral, enteral, or parenteral nutrition. So ask yourself, is all nutrition therapy a component of medical treatment? Everyone eats, so I guess we consider that normal nutrition. And then nutrition therapy is when there is a medical diagnosis that requires a special nutrition regimen. In the end, it probably doesn't matter because only we clinicians actually use these terms. One of the most important points of this slide and definition is that nutrition support therapy is oral, EN, and PN. All of them, or two, or one. Each of these therapies is a tool in the nutrition toolbox that the nutrition support clinician can use to meet an individual's nutrition needs. There is a document, it's on Blackboard, it's called Official Definitions. So it's definition of terms, style, and conventions used in Aspen Board of Directors. It's approved documents. You can refer to that on Blackboard, and it's basically its definition for nutrition support or nutrition support therapy, and it is parenteral and or enteral nutrition. Don't spend time studying this by any means, but it does provide a nice list of approved and official definitions that you may come across and or use in your careers. Just side note, in general for this class, something to keep in mind is that there are several articles and supplemental readings. Please don't kill yourself trying to read and absorb everything. I'm not testing you over specific things that were found in these articles, but these are there to help further supplement the material taught in this class that you're interested in or have questions about, and they're also just good resources for you to refer to later on in your careers. Can't tell you how many times, a physician has an opinion about something, and then it's easy to have an arsenal of articles just to back back up what you're saying. So here's just an example of the nutrition team. While the duties might change slightly in each facility, this just describes the general job of each team member in the nutrition support process. Of course, some facilities do not have a formal nutrition support team, but often the dietitian, pharmacist, and physician all work towards prescribing the appropriate enteral or parenteral nutrition regimen. Um, don't underestimate or forget the nurses. The nurse is extremely important as they're the ones who sees the patient daily and for an extended amount of time. They're going to be the first ones to know if there's any tolerance issues or if there's an issue with the line or feeding tube that needs to be addressed. So enteral nutrition is nutrition provided through the gastrointestinal tract via tube, catheter, or stoma that delivers nutrients distal to the oral cavity. So also known as tube feeds, and this definition comes from the Nutrition Support Core Curriculum, and it's much better than the definition that was given by the Academy. Parenteral nutrition is one of the ways that people receive nutrition when they cannot eat or use their GI tract for enteral feeding. It is a special liquid mixture that is given directly into the blood through an intravenous tube into a vein. The mixture contains all the protein, sugars, fats, vitamins, minerals, and other nutrients that are needed. It was once called total parenteral nutrition, TPN, or hyperalimentation. This definition also comes from nutritioncare.org. It's parenteral nutrition is often called IV nutrition. TPN tends to be more of an umbrella term. In the definitions and conventions used by the Aspen Board of Directors document, parenteral nutrition is defined as the intravenous administration of nutrients. It's further subdefined as central PN, which is parenteral nutrition delivered into a large diameter vein, usually the superior vena cava, adjacent to the right atrium, or it's peripheral parenteral nutrition, which is parenteral nutrition that is delivered into a peripheral vein, usually of the hand or forearm. This picture depicts the most common ways that nutrition support is administered. Enteral nutrition or tube feeding can be accessed by nasogastric, gastrostomy, jejunostomy, nasojejunal, or nasoduodenal tubes. Enteral nutrition delivers nutrients into the GI tract. With parenteral nutrition, nutrients are delivered directly in the bloodstream via central access, which would be CPN, or peripheral access, PPN. So who needs nutrition support? If we consider nutrition support as EN and PN, then who needs this therapy? Maybe someone can't eat. This could be due to disease, injury, illness, or even secondary to treatment. Think of your head and neck cancer patients that might be receiving radiation to that area. In Module 2, diseases requiring nutrition support will be discussed in a little bit more detail. Maybe the patient can't eat enough. Maybe we've gone down the route of modifying diets and adding oral supplements, and it's still not enough. Another important question, really the first question that you need to be asking yourself at this point is, does the GI tract even work? Is it functional? This includes the entire GI tract, the mouth, the throat, esophagus, stomach, and the small and large intestines. While EN is considered the most physiologic feeding, if there's malabsorption present, then EN might not be adequate to meet the patient's needs. There are other conditions such as chyle leaks and perforations which make it impossible to use the GI tract. A very key question before moving forward with any kind of nutrition support is to determine if feeding is truly indicated. This is related to the disease state, but also the prognosis. The goal of therapy must be considered at the onset of any kind of nutrition support. Even with enteral nutrition, there is a need for access, which may be minimally invasive if we're talking an NG tube, but if outcome is predictably going to be poor, then there might not be a reason to initiate the therapy. As always, individual and family desires have to be accounted for, but it's up to the nutrition professional to help the patient and family make informed decisions about their care. But first, we have to answer the question, who needs nutrition support by answering, is the patient at nutrition risk? That is risk for malnutrition. Nutrition screening. Based on clinical outcomes data, the nutrition screening is an important first step in identifying individuals that are at risk for malnutrition. This figure here is clearly screening for patients in the hospital. You can review this article by Mueller and colleagues to better understand the nutrition screening process if you feel like you need that. Aspen defines the goal of nutrition screening as the ability to identify patients who are malnourished or at risk to become malnourished. The challenge in the outpatient setting is the ability to have a screening process that is organized and has well-documented indicators related to nutrition risk. A nutrition screening tool should provide a quick, reliable, and applicable evaluation of nutritional risk. This is Table 1 from that article by Mueller and colleagues. Selected nutrition screening and assessment instrument parameters. They're listed here in this slide and they're reviewed briefly in the article. Each tool has pros and cons based on the setting to which it is applied. The nutrition screening form/tool can be used to collect information on what the patient hopes to accomplish and goals of therapy. The nutrition-focused clinician is most adept at analyzing the results of the screening, which may have been administered by a nurse, nurse aide, or even a non-medical professional. For the dietitian that's working in an outpatient clinic or a private practice, the initial forms completed by the patient prior to a consult might include those nutrition screening questions. The Nestle Mini Nutrition Assessment, or the MNA, it's a short, concise, and well-validated tool to identify the presence of or risk of malnutrition in individuals that are age 65 or older. The tool contains 6 questions on food intake, weight loss, mobility, body mass index or BMI, and dementia, so it's particularly applicable to that geriatric population. It's also available on mobile devices as well as paper and for incorporation into the medical records. The Subjective Global Assessment, or the SGA, is a screening and assessment tool which incorporates elements of the client's weight and intake history, disease status, and physical findings. From these data, clients are categorized as well-nourished, moderately malnourished, or severely malnourished. The SGA has demonstrated predictive value for nutrition-related complications. It may be a little bit too involved, though, to be a quick screening tool. In the hospital setting, you're most often going to have to rely on your nursing admission nutrition screens and physician consults to identify patients at risk. It's also important that you recognize those high-risk diagnoses such as COPD and certain cancers as you're going through your census, deciding who needs to be seen for the day. Body mass index, or BMI, is a practical measure of body size and indirect measure of body adiposity. It does not account for gender, age, ethnicity, fitness levels, or variation in abdominal adiposity, and therefore it should be interpreted cautiously. It has been shown that mortality is sharply increased with a BMI less than 18.5 or greater than 35, and also the highest and lowest ranges are at heightened risk for malnutrition. And I've included here a table of BMI and the classification. And another thing that it's important to remember in your practice is that you can be malnourished at any BMI. It is not just your BMIs of 17, 16, 14. Those are not the only ones at risk for malnutrition. Patients that have BMI greater than 40 can still meet Aspen criteria for malnutrition, and it's important that you don't just write those patients off just because of their BMI. Table 3 from the article by Mueller, grading of guidelines and levels of evidence. So by evaluating these tools, nutrition support guideline recommendations for adult nutrition screening and assessment can be achieved. This slide just shows how the guidelines were graded and related to the levels of evidence. Anytime a tool, guideline, or standard is graded, it's important to know how they were graded. Notice that a level 5 definition in some papers, it states that it's based on case series, uncontrolled studies, and expert opinion, otherwise known as "someone once told me this." Here are the nutrition support guideline recommendations in adult nutrition screening and assessment. I find it quite interesting that number 1 and number 2 are grade E. I think we can all agree that it is important to screen patients for nutrition risk and follow this with a nutrition assessment, But is there actually evidence to support this? Perhaps maybe there just isn't adequate research on this topic yet to make a blanket statement. But it seems strange to me that number three would have a C level of evidence without number one and number two having that same level of evidence. So this is the article I pulled, and I'll be reviewing just as a sample article review. And I'm going to provide the abstract to this, and then the review will be available in the Module 1 folder. Here is the abstract for this article. The key takeaway here from the conclusion is there is compliance with completing a nutrition screen within 24 hours of admission, so most people are doing that, and that most hospitals have a process to perform a nutrition assessment once that screen has been completed. However, where there needs to be more research is that there's inconsistencies with which tools are being used and how coding for malnutrition is actually captured. Now, let's assume that nutrition risk has been identified. The next step is going to be to conduct a nutrition assessment. And although this course is specific to enteral and parenteral nutrition support, it's still very important to understand the nutrition assessment. In a nutrition assessment, information is collected from a variety of sources. You take a history, clinical signs, physical exam, medical and surgical diagnoses, anthropometric data, biochemical data, which is your labs, intake, and functional status. And all of this is evaluated to develop a statement about the patient's nutrition status. In the enteral handbook, table 1.3 and 1.4, they provide comparison of laboratory markers, physical exam, and medical history. Tables 1.7 and 1.8 review dietary assessment methods. For instance, 24-hour recall, it may be helpful for your clinic patients. It is a technique we learned way back in undergraduate school. And again, in the right situation, it can be a key element of the nutrition assessment. That being said, I don't use it often in the hospital setting. I have used it, but not often. Body composition studies, these are often not available at all, and if so, they're most applicable to the non-acute, non-ICU patient. The laboratory data that's listed in the tables is pretty comprehensive, but note how the labs are related to malnutrition and not the disease state. So, of course, albumin is not going to be a reliable indicator of nutrition status. So, what is the evidence to support nutrition assessment in critical care? If you review the Aspen and Society for Critical Care Medicine guidelines, you'll see that the tools we've used for years to assess nutrition status are not valid in critical care, and this can be translated to acute care as well. I know it says 2009 guidelines, but it's still relevant for the 2016 guidelines as well. But the best tools to use are evaluation of weight loss. So, has the patient lost weight prior to admission? If so, how much and in what period of time? What was their previous nutrition intake like prior to admission? Were they eating their usual amount, more, less? They have a poor diet quality overall. Disease severity, is this critical care? Is this an acute event? Do they have chronic disease with underlying inflammation? Comorbid conditions such as diabetes, renal disease, cancer, and then function of the GI tract, which is really a point to determine what nutrition therapy to recommend once the feeding is initiated. This study, Malnutrition Syndromes, a Conundrum versus Continuum, that was published in JPEN, it's a little old, from 2009, but it was a landmark study, and the authors set out some important points that set the stage for the new way to understand and discuss and manage malnutrition. Basically, they proposed that the usual diagnostic criteria for malnutrition were not useful. Further, cachexia is malnutrition with underlying inflammation, which is why it is so difficult to treat and important to avoid. Inflammation is a key factor in malnutrition, and the degrees of inflammation, acute to chronic, that set the stage for the diagnosis and treatment of malnutrition. And this is an excellent article to review regarding malnutrition. Here's a decision tree for determining severity of malnutrition using the subjective global assessment. Chapter 1 goes into detail about nutrition assessment and diagnosing malnutrition. This should be somewhat of a review for you, but if not, be sure to read this. Again, the proper diagnosis of malnutrition is really important, and this also may be a review for you. But please refer to Chapter 1 and the information that I'm about to go over so you can properly determine the type of malnutrition your patient may be experiencing. So malnutrition in a patient may be considered mild, moderate, or severe. Now remember, mild malnutrition really only applies to the pediatric population. In adults, we only have moderate and severe. But what do these terms actually relate to? We're going to use the same tools that we previously discussed to identify nutrition risk. So macronutrient intake, is it compromised? How were they eating before they came to the hospital? Is there a loss of body mass? So your evaluation of muscle wasting and fat loss in your nutrition-focused physical exams. Weight loss. Has the patient lost weight prior to admission? If so, how much and in what period of time? Next, is inflammation present? What is the disease severity? Is this critical care? Is this an acute event? Or is this a chronic disease state? When you put all these questions together, you come up with an answer that tends to fit into one of three categories. So, first one is malnutrition that's related to social and environmental circumstances. It's pure starvation. So, there is no inflammation present, but there is nutrient intake compromise and weight loss. We used to think of this as marasmus. And so individuals in this category could be those with maybe anorexia nervosa, for example. Second type of malnutrition is related to chronic illness, and that means inflammation is present in mild to moderate intensity, as well as nutrient intake compromise and weight loss. So we used to think of this as cachexia, which that really is defined as inflammation plus intake compromise and weight loss or body composition changes. Individuals in this category could be those with chronic pancreatitis, for example. The last type of malnutrition is related to acute illness or injury. There is inflammation present in moderate to severe intensity, but it's acute and it may or may not be associated with nutrient intake compromise or weight loss. We used to think of this as protein energy malnutrition. This is the effect of burns, trauma, or an acute occurrence that causes an intense inflammatory response. It's usually self-limited in that it's not a chronic disease, although it may still have long-term consequences. Individuals in this category, like I said, can be those with burns, trauma, or acute injury, for example. So you have made the decision to provide nutrition therapy. So we have to decide, how are we going to feed? Our nutrition mantra remains the same. If the gut works, we want to use it. However, I would like to add to this and use the nutrition toolbox. The point here is that we have at least 16 different combinations to meet nutrition goals through oral intake, supplements, enteral, and parenteral nutrition. The easiest might be oral diet plus supplements, but the nice thing here is that you have the ability to choose one option or a combination of any of these. We want to try and follow a stepwise approach when selecting the optimal feeding route. We want to obviously begin with oral diet and progress according to the patient tolerance and all the way to parenteral nutrition if it's needed or indicated. Alternatively, a patient might start with parenteral nutrition and they might be able to move down to enteral nutrition or even oral intake. And remember the combo plate. It is totally okay and sometimes even necessary for these therapies to overlap. It's very important to always evaluate if and when the patient is ready to transition from one form of therapy to another. Here's the nutrition toolbox that I keep talking about. The point here is that one type of therapy does not preclude use of another type of therapy. This is indeed the circle of nutrition, which relates directly to the circle of life. You know, there are many pediatric patients out there who receive parenteral nutrition as their primary method of nutrition therapy, but they might also have a G-tube for trophic feeds, which that's enteral nutrition that's given in small amounts at a low rate, anywhere from 5 to 20 mLs per hour for gut stimulation. They may also be able to take oral feeds for pleasure. These patients, they truly have the entire combo platter. Now, how many calories? The next step in the nutrition assessment process is determining how many calories the patient requires. Nutrition therapy, whether it's oral, enteral, parenteral, it's based on GI function. This may already be determined, or it may be based on how many calories the patient requires versus how much their intake is currently. The components of energy needs include basal metabolic rate, or your BMR, which is your energy needs at complete rest, which means that the key components are to support major organ function, and this accounts for about 60 to 80% of total calories. Your resting metabolic rate, that's 10% above your basal metabolic rate. So you're awake and there's some movement, but no food or activity involved. and this typically represents 60 to 75% of the total energy expenditure, or TEE, which TEE is your daily energy needs in free living people. The thermogenic effect of food, which is the energy needed for digestion and absorption, and it accounts for about 6 to 10% of your total energy expenditure. And all energy needs are based on the amount of physical activity or the effect of disease or illness or both. The respiratory quotient, or RQ, measures the ratio of the volume of carbon dioxide, VCO2, produced to the volume of oxygen consumed, your VO2. So the RQ equals VCO2 divided by the VO2. RQ was once thought to be useful as a means to determine the source of the substrate metabolism, so whether you're burning fat, carbohydrates, or protein. But we now understand that the application of RQ as a marker of substrate use has limited clinical usefulness. RQ that is outside of 0.67 to 1.3 really just infers serious problems with the test validity, and it's usually the result of human or machine errors. Here's a table just how to interpret the RQ value, but like I said, recently there's been a change in how clinicians really view the value of RQ to determine energy needs and don't really use it much in actual practice. So indirect calorimetry, we've all heard that that's the gold standard for determining energy needs. There's really no absolute indication for indirect calorimetry, but it might be useful for those who have a body mass index that's really low or really high. You could use it if you're concerned about overfeeding a patient that has unexplained high ventilator requirement or for an unknown reason can't be liberated from the ventilator. Those that have massive tissue loss from amputations, and somebody that maybe had pre-admission fluid overload like ascites, received a bunch of volume resuscitation, their third spacing, without a reliable report of body weight at a proper hydration status. But all these indications, they're relative. Using predictive equations, the metabolic rate of an underweight, critically ill, or acutely ill patient, it's more likely to be inaccurately predicted using those equations than the metabolic rate of a normal weight or even an obese person. So, therefore, a patient with a low BMI might be a good idea to get IC if it's available to you. But honestly, if you're using equations and if the calculated calorie needs don't result in extra respiratory distress or any further weight loss or weight gain, then IC is probably not necessary. So there are actually several absolute contraindications for indirect calorimetry. Recall that IC is a respiratory measurement that under proper conditions is equivalent to metabolism. And so any factor that violates these conditions is a contraindication to indirect calorimetry. If RMR is the desired value to be measured, then any factor that prevents that patient from being at rest or cooperative with the device is also a contraindication. So any kind of air leak, if you have chest tubes, cuff leak, or any other leak in the ventilator circuit, you shouldn't use IC. Patients on ECMO, patients that are on hemodialysis, you shouldn't use IC during hemodialysis and for several hours after the dialysis. If you're, for mechanically ventilated patients, if their fraction of inspired oxygen or their FiO2 it's greater than 60%, you also want to avoid IC. And then for spontaneously breathing patients, they can't be relying on any kind of supplemental oxygen, and they have to be able to cooperate with the measurement. And so claustrophobia or any anxiety about the measurement could also cause the measurement to be inaccurate. What is the evidence to support indirect calorimetry versus equations to estimate energy expenditure? So, can the RMR be measured reliably? Yes, it can, but it's under certain standard conditions to be able to obtain that steady rate RMR, and it is slightly less reliable in ventilated patients. But overall, weekly IC studies are no more accurate than predictive equations. If you have access to the Nutrition Support Core Curriculum, Chapter 2 discusses indirect calorimetry in critically ill patients if you want to dive deeper on that on your own. Here are the predictive equations that we'll be discussing. There may be others, but these are the most widely used and researched ones. Equations that estimate basal energy expenditure or resting metabolic rate are going to be your Harris-Benedict and your Mifflin-St. Jeor. For critically ill patients, we have the Penn State equation, the Ireton-Jones equation, and we also have the Aspen guidelines. And then just remember there is individual variation caused by factors not in the equations, like percentage of lean body mass, obesity, ventilation, stress, and trauma. This is the Mifflin-St. Jeor formula. It has one for males and for females. These equations were published in 1990, and they were developed by Mifflin and St. Jeor. There were almost 500 people in the study, which was about 50-50 males and females. And the equation is relatively representative of the population, as about 47% had a BMI greater than 30 and up to 42. The equations have been found to be valid for males and females. The Academy Systematic Review found more favorable evidence for the Mifflin-St. Jeor equation than for any other, although the accuracy rate of the MSJ does fall somewhat when it's applied to obese people. It was 75% accurate with people with a BMI of 30 or higher and 87% accurate with BMI of 30 or less. For weight, make sure you use kilograms, and height is in centimeters, and age is in years. The difficulty in obtaining accuracy here lies in choosing the appropriate stress factors. Use of this formula for patients on nutrition support is probably not as accurate as other equations. In practice, this formula is used frequently, but the activity factor is not added in the hospital setting. You only add an injury factor. So this table, it comes from an article that looked at validation of several established equations for resting metabolic rate in obese and non-obese patients. Basically, the takeaway here is that Mifflin was more accurate more often than Harris-Benedict equation or the Owen equation. We're not really going to talk about the Owen equation, but the Harris-Benedict equation really has now been transitioned from a clinical tool to a historical landmark. It was published in 1919, and it represented the first use of regression techniques in physiology. It established linear rather than allometric scaling for calculating resting metabolism. An allometric describes a change in one biological parameter that is not linear with another. This equation, it really tends to overestimate the true resting metabolic rate, and this observation has been documented in validated studies. Like I said, this slide just shows the accuracy of the Mifflin-St. Jeor equation compared to two other equations, including the Harris-Benedict. In 130 subjects, which included some obese individuals, their measured RMR was compared to the predicted RMR. Clearly, Mifflin-St. Jeor equation has the highest accuracy even with obese individuals. But they did not include the modified Penn State or the Aspen guidelines for obesity or Ireton-Jones equations for spontaneously breathing patients. Side note here, working in the ICU setting at the height of COVID, I saw a ton of patients that had BMI greater than 50, even 60 and above. I still believe that more research is needed in critically ill, supermorbid obese patients. When determining calorie needs in the outpatient setting, you might consider adding factors to account for activity. Use your clinical judgment if this is necessary or not. It may still overestimate for some clients. However, these patients, you should not have to add a significant injury factor. For truly sedentary individuals, a 10 to 20% increase above RMR may be all that is necessary to meet energy needs. A 500 calorie factor has been used to add to the daily energy expenditure to gain weight or subtract that same amount to lose weight. Recent data has shown that the 500 calorie number, it might be incorrect. There is an article that's on Blackboard by Thomas Gonzalez, Pereira, Redmond, and Heimsfeld. It was the JAND article in 2014. If you want to review that, you can if you're interested. Energy expenditure in critical care is affected by whether or not they're ventilator dependent versus spontaneously breathing, and if they're on the ventilator, what kind of ventilator support, what are their settings, what's their minute ventilation. It's affected by the type of nutrition support received, their height, weight, age, sex, body temperature, sepsis, as well as their diagnosis. Just remember that applying predictive equations that were developed for normal, healthy subjects to critically ill patients, it might result in significant errors. The Penn state equation can be used if your patient is on a ventilator. These equations are based off of a calculation of the Mifflin-St. Jeor equation, and it uses maximum body temperature of the day and minute ventilation obtained from the ventilator settings. Keep in mind the temperature, ventilator settings are your injury factors, so you don't add any activity or injury factors to this formula. Accuracy differs depending on the condition of your patient, but generally the Penn state has about a 75% accuracy rate. Here are the Ireton-Jones equations for ventilator-dependent and spontaneously breathing patients. There is no additional factor that is added for activity or injury. These equations were developed back in 1992. Validation studies have shown that this equation has a low accuracy rate in mechanically ventilated critically ill patients. The Academy Nutrition and Dietetics Evidence Analysis Library for Critical Care Nutrition does not recommend the use of the Ireton-Jones equation except for in burn patients. So here are the Aspen recommendations, or the Aspen guidelines. These recommendations can be followed based on the weight of your patient, and once the BMI is greater than 30, practitioners may refer to this as permissive underfeeding. The theory behind permissive underfeeding is that we're trying to force fat mobilization, which was not happening when they were being fed at 16 to 20 calories per kilogram of actual body weight. There is some research out there emerging that regards the use of adjusted body weight for a BMI of 25. This has been shown to be effective for older adults, shorter obese women, and tall men. And like I said earlier, I really think we need some more research for the super morbid obese patients that have those BMIs greater than 50, greater than 60. But for now, current research supports that if your patient is obese, you should be using one of these formulas. You should be using the Aspen guidelines or a modified Penn state. All of these equations have a degree of accuracy, and the practitioner needs to be aware of the frequent inaccuracies that may occur, and you've got to apply your clinical judgment to assess the appropriateness of nutrition therapy that's derived using these equations. If you have the Nutrition Support Core Curriculum, Chapter 35 discusses complications in determining nutrient needs with critically ill obese patients, if you're curious. But definitely, like I said, more research is definitely needed. Here is that Penn state equation that has been modified for obese and elderly. You should use this version if your patient is older than 60 and they have a BMI that's greater than or equal to 30. It's modified due to inaccuracies. Previous research was showing that the calorie level was too low in older obese patients. And then research shows that this modified formula is actually 80% accurate in obese patients. And remember, your patient has to be on the ventilator. What formula do you use? This is going to depend on several factors. So what you need to ask yourself is your patient critically ill? Are they mechanically ventilated? Is your patient obese? If any of these applies, then this narrows down your choices a bit. The important things that you need to remember for the exam and in your practice is that the research points to Penn state equation as being the most accurate if your patient is on a ventilator. If your patient is obese, the modified Penn state formula is most accurate if your patient is on the ventilator and is greater than 60 years old. Otherwise, you need to use the Aspen guidelines for obesity. And then if your patient is not critically ill, then Mifflin-St. Jeor is the most accurate. In summary, nutrition support therapy encompasses enteral nutrition, parenteral nutrition, and oral nutrition. Energy needs are calculated using energy equations, or they are measured by using indirect calorimetry. And then in Module 2, we're going to discuss macronutrients, micronutrients, and disease states.